Hello and welcome to week 5 of Understanding and Improving the U.S. Healthcare System. I'm Dr. Matt Davis, the course director, and I welcome you to this live session where we're going to go through the preliminary data from your CHAT individual health plan selections, and I'll be answering the questions that you've posed on the course website. We're going to start this session taking a look at your selections from the CHAT individual health plan. Up on the screen now is the CHAT game board that we've developed here for our course. This should hopefully look familiar to you. If you're looking at this week 5 content and you have not yet completed your week 4 exercises for the CHAT individual health plan or the CHAT stakeholder groups plan, please go back now to the week 4 content and go through that exercise. It's going to be a lot clearer to you what we're going to talk about in week 5 if you've already gone through week 4 yourself. So to return to the CHAT game board, we see here the different levels within the different benefits categories and the overall set of 15 categories that contribute to the health plans that you've developed. On the right-hand side of the board, home health care, emergency care, dental care, alternative medicine, vision care, tests, specialty care, and primary care. And on the left side of the board, hospital care, infertility, last chance options, long-term care, mental health care, other medical services, and pharmacy. I really thank all those of you who have contributed your CHAT individual plan selections through the unique survey links that you've received either in email or seen on the announcements on your version of the course website. We've heard from several hundreds of you. I welcome those of you who have not already put in your CHAT individual plan selections to please do so. If you have those selections in hand and you haven't put them in yet, I welcome you to do so before you watch the rest of this session today. If you'd like to go ahead and finish watching this session and have your benefits ready at another time, please go ahead and put them in because we'd very much like to be able to report out as many students as have responded by the end of November 2013 when this course closes. I'll be sending out the findings from the CHAT individual health selections and the CHAT stakeholder group selections to all of you who've enrolled for this course by the end of November 2013. I encourage those of you who may like to see those findings in detail to keep coming back to the website and or to follow us on Twitter and link into us on Facebook, where we'll be making announcements about the availability of those findings later in November. Now let's move on to the descriptions of your own CHAT individual health plan selections. I'm going to present to you today preliminary data from the nearly 900 students who have already completed their selections. So let's take one by one. First of all, alternative medicine. The most common choice was 0, no alternative medicine, although there were some students who clearly thought about this long and hard and contributed their thoughts in the discussion forum. I encourage those of you who may want to read more about alternative medicine and some of its benefits perceived by some of our students to go check out those threads on the course website. For dental care, the most common choice level was 1, which was the lower level. There was a higher option that was possible, but here the most common level was level 1, which is 2 markers. Emergency care, level 1, 2 markers. And home health care, level 1, also 2 markers. So each of these, although they had higher levels, were most commonly chosen at the basic level of level 1. We're going to present hospital care later. Infertility, like alternative medicine, had a most commonly chosen level of 0, no coverage. Last chance, which are things like organ transplants, had a most commonly chosen level of 1, which cost 1 marker. And long-term care, also level 1, which cost 4 markers. Some of you asked, well, does long-term care really fit into a healthcare plan like this? Because you're accustomed to seeing a long-term care insurance plan bought separately. And that's a question I'm going to address in the second half of this session today. On the right side of the screen here, we have mental health care, most common choice 1, level 1, 2 markers. And other medical services also had the most common level chosen as level 1 at 2 markers. We'll talk about pharmacy, primary care, and specialty care later because they required more markers, or you could opt for more markers in those categories. And that leaves us with 2 more at the bottom on the right, tests at level 1 and vision care at level 1. Tests required 3 markers at level 1 and was therefore similar to long-term care in terms of a fairly or comparatively large devotion or commitment of markers in order to get that first level of care. And vision care was also at level 1 with just 1 marker. So far with these smaller types of benefit categories, we have 2, 4, 6, 9, 13, 15, 17, 20, and 21 markers that we've used so far. As you recall, our spending constraint here was 50 markers. So we're not quite to that halfway point with the average selections that have been made by the group so far. We have 4 categories left. They are the largest in terms of the numbers of markers that you would need in order to get this type of coverage. So let's take a look at what the majority opinion was in these remaining categories. First, on the left-hand side, we have hospital care. As you recall, there were 3 levels, and the most commonly chosen level here was level 2, which required 11 markers. In level 2, you had a little bit closer hospital, a bit better set of options in terms of the copays and access, and yet the doctor was still encouraged to push you out sooner, which typically would have led, as I commented in one of the threads in the discussion forum, to spending more time in a skilled nursing facility, a lower cost type of facility. So level 2 was most commonly selected for hospital care. At 11 markers, that is already increasing the commitment of markers by 50% over what we'd had with the smallest categories alone. What about pharmacy? Pharmacy, the most commonly chosen level, perhaps somewhat surprising to some of you, was level 1, because some people certainly chose level 2 or even level 3 for pharmacy, which level 3 required 8 markers total, but the most commonly chosen level was level 1 for pharmacy, which, as you recall, would require your doctor to prescribe medicines on the formulary and had a higher cost sharing, higher copay for those medicines if you were to pick them up at the pharmacy. That leaves us with primary care and specialty care. Primary care had the highest level selection of any category in this group among you all as students. The level that was most commonly chosen was level 3. It was very close. Level 2 was also chosen fairly frequently by, if I recall, about 37-38% of the students, but level 3 was chosen even more commonly, and that would require 6 markers. That leads us to, finally, specialty care, which, like hospital care, was chosen most frequently at level 2, requiring 11 markers. These selections may mirror what you chose. After all, these are the majority selections. But for those of you who pick differently, think about how your different selections may have required you to pick differently from other categories as well. Because, of course, if you're trying to sum all these to 50 markers, and for those of you doing the math, you can see that the majority, of course, because you all are good at math and follow directions, we're at 50 markers when we take a look at the most commonly selected categories. But if you chose something different, for example, for alternative medicine, you must, in order to reach that 50 marker total, have chosen differently on at least one other category as well. Take a moment looking at this table and see how your selections may have differed. All right, now what we're going to do is go a bit more in depth at these choices from you all for your chat individual health plans and see what we can analyze regarding your selections and what they meant in terms of these trade-offs. First of all, we asked you, how difficult was it for you to stay within the spending constraint of 50 markers within your individual plan benefits? You may remember this on the survey as a speedometer type of measure, ranging from 0, not difficult at all, to 10, extremely difficult. What we found is that the most common level of difficulty that you all reported, or the mode that you would call it in statistical terms, was 7. That was the most common answer. But the mean answer was right in the middle, as we might expect for this sort of question in a fairly randomly, although self-selected audience, because you all wanted to be in this course and wanted to be part of this simulation exercise. So the mean answer was 5. And I'm not showing you these data here, but what we see is a very beautiful bell-shaped curve slightly shifted over to the higher end of the scale in order to get that most common answer of 7. We then asked, if you were given the option to buy, quote unquote, additional markers to design your individual plan, how many markers would you have wanted to buy? And the options were anywhere from 0 to 37. 37 being the maximum number of markers that could have fit onto the game board. And what we found then is that 8% of you said, actually, you didn't need any more markers. You were fine with that spending constraint of 50 markers, and it was all set for you. Several of you wrote about that in your comments on the discussion forum, and I appreciate hearing that because, after all, some of us are fortunate to be in fairly good health, and we really need that plan to cover the catastrophic types of spending that we can't foresee, but we want to be prepared for. That said, the number of people who said it wasn't that difficult an exercise and they easily stay within 50 seemed to me to be a bit higher than just 8% of the group. Don't be fooled. Although people may express themselves very well on the discussion forum, they don't necessarily represent the majority opinion. So, always helpful to have some data to go along with the stories that are part of this classroom as well. At the other end of the scale, 1% of the students in this course said, you know what, I would want all the rest of the markers that would be possible. Well, how did the rest of the students fall in between those numbers? And what we can see here is that 22% of the group said they would want 1 to 5 additional pegs. 41% of the most common choice was that they would have wanted 6 to 10 additional pegs. 22% 11 to 20 additional pegs, and 6% 21 to 36 additional pegs. Let's take a step back for a moment and think about what does it really mean to say, I wanted more markers. I wanted more pegs. What you're essentially saying is, I wanted more coverage, and I would have paid more in order to get it. Of course, that is how the U.S. healthcare system works on the private side right now. You can, if you have the financial wherewithal, if you can afford it, you can find a plan for which you will be prepared to pay more and that will give you more benefits. We'll talk a bit more about this as I answer your questions that you posted in our forum in the second part of this session today. Now let me share with you a type of analysis that is something that I've worked on after looking at the patterns of the different marker selections that you've made. In other words, you answered my questions about, well, how difficult was it, and if you could buy more markers, how many would you want? Now what I'm about to show you is a statistical analysis called a pairwise correlation of what you selected and what therefore you would have selected along with it or would have traded off in order to make your selections meet that 50 marker spending constraint. So I'm going to show you some examples here of these. We don't have enough time for me to show you all of them, but I want to give you some really illustrative examples to be able to say, oh, I didn't know that about my own thinking, or I would expect that might have happened in terms of trying to meet that 50 marker spending constraint. So here I've listed on the left-hand side of the screen 4 types of benefit categories: alternative medicine, dental care, emergency care, and hospital benefits. And I'm going to show you in the middle column the types of benefits that each of the benefits on the left matched with in terms of, and what I mean by that is, if someone chose alternative medicine, what were they also much more likely to choose than other categories? And in the opposite direction on the far right, if they were to choose alternative medicine, what do they typically not choose, either at all or as much of? And you can determine these types of relationships by using that correlation test that I spoke about before. This is a very basic, fundamental form of statistical reasoning and analysis that actually tells us a lot about decision making. So let me go through each of these rows here for these 4 benefits that are designed to look at fairly different parts of our chat game board. We'll start with alternative medicine. As you recall from earlier in this session, alternative medicine had a most common choice of 0, no coverage. You might also recall that there was one other option there, which was to choose 1 marker for a basic level of coverage there for alternative medicine. If someone opted for alternative medicine, they tended also, in the middle column, to opt for infertility coverage and vision coverage. And on the trade-off side, if they chose alternative medicine, they tended to choose lower levels of hospital care, pharmacy benefits, primary care, specialty care, and tests, let's think about what it means that if someone opted for alternative medicine, they were trading that off against hospital care, pharmacy, primary care, and specialty care. You recall that those categories, those four, are responsible for the majority of markers on the chat game board. Yet alternative medicine is only worth one marker. What I'm suggesting to you is that this is not purely mathematical. You don't have to select less of hospital, less of primary care, and less of subspecialty care in order to get that one marker for alternative medicine. Instead, what appears to be happening in terms of your decision making as a group is that if you are thinking alternative care would be helpful, you are also tending to choose less coverage in terms of these other main types of healthcare as we perceive them to be valuable in the U.S. healthcare system. In other words, there's a mathematical reality, and then there's the overall approach to selecting benefits and appreciating and understanding what would be helpful for you. Let's now go to the second category of dental care. Here with dental care, you can see it matches with vision, but it trades off with home health, long-term care, other medical and specialty care. Notice how different dental care is than alternative medicine in terms of what the trade-offs were. In fact, there's only one benefit category that is similar to alternative medicine in terms of the trade-offs for dental care, and that's specialty care. Again, this is not purely mathematical. There is some thought process going on for people when they consider dental care and how it relates to these other types of healthcare benefits that are available in this chat simulation exercise. Below dental, we have emergency care. People who tended to vote for more benefits in emergency care also tended to vote for more benefits in terms of pharmacy care. An intriguing idea, right? That you depend on, or you believe that more emergency care would be beneficial to you, and so would more pharmacy care. To me, this suggests a possible approach to thinking about healthcare as I can and do depend on, I have high expectations of high-tech type of care. Emergency care trades off against home health and long-term care. As you might expect, while there is some mathematical reasoning to this, there's also a very fundamental approach to thinking about what you need protection for. So if you're emphasizing emergency care protection for yourself, you may be valuing less the option to have coverage in home health and long-term care. The final example here is hospital. Matching well with primary care, specialty care, and tests. That may seem counterintuitive because after all, the primary care, specialty care, and tests are some of the more expensive categories. On the other hand, they represent the core parts of the healthcare services that are available in the U.S. healthcare system in terms of expenditures. Hospital benefits tended to trade off against long-term care and mental health care on the far right. So this sort of comparison, as you can see, tells us a bit different story about how you made your decisions and how, as rational individuals trying to meet a spending constraint, you made certain trade-offs in thinking about the types of protection, the types of benefits you would want in your health plan as an individual. This is a reminder at this point that while the chat individual health plan findings are quite interesting so far, and I encourage you, if you're watching this and you haven't put in your chat individual health plan selections, to please go ahead and do that. We'll be sharing the final results of the chat individual health plans by the end of this course at the end of October. We also are hoping to hear from more of you about your chat stakeholder group assignments. Slightly fewer of you have contributed your stakeholder group assignments than have contributed your chat individual plan assignments or individual plan selections. And I really encourage you to participate in this part of the exercise as well, to be responsible for making decisions about health plan benefits for someone else. I know and I recognize from the comments on the course website that this is a challenging part of the exercise. After all, for the vast majority of U.S. students, you haven't been asked to think about someone else's health plan benefits before. But that's part of this exercise to understand if we were to have a more uniform approach in the U.S. to health plan benefits, how might that work in terms of considering the needs and values and perspectives of different stakeholder groups. Because we're early on in the data collection for your chat stakeholder group options, I'm not going to present those preliminary data here in this session, but I will be sharing those by the end of, beg your pardon, I think I said October before, I meant November 2013. I'll be sharing the individual plan results and the stakeholder group results through the course website. So that brings to a close the comments I have today about your selections for chat individual health plans and chat stakeholder group health plans. I'd like to spend the rest of our time during this live session giving you some responses to the very thoughtful questions that many of you have put up on the course website. I recognize that for limitations of time, I may not, or I can't get to all of the questions you've posted, but what I've done in this session here today is to highlight some of the major themes in the questions, and I've selected particularly illustrative examples of those questions to share with you today on the screen and then respond to them. I realize they're showing up for you now all as one slide of multiple questions. I'm going to take them one by one and try to tell a story about how chat can help us learn about the healthcare system and what that means then for your selections in your health plans and how you can help shape them going forward in the U.S. healthcare system, or for those of you participating in this course from outside the United States, in your own systems. I have 2 slides here of the questions from the students, and I believe the total is around 15 questions overall. If you don't have your question answered as part of this live session, I welcome you to submit your question through the Week 5 discussion forum thread, and or submit your question through Twitter or through Facebook. And those accounts we've set up through the course website, and we welcome you to follow us on Twitter and contribute to the Facebook discussion if you'd prefer. I should emphasize that we may not be able to answer all the questions that are posed. I will try to get to as many of them as I can. Please don't interpret a lack of an answer, if you perceive a lack of an answer, as any slight or problem with your question. It's mostly a matter of time and volume of the correspondence that we're receiving. So let's now go to the questions. Question number 1. I purchase long-term care, dental, and vision care separately from my employer-based health care. Does the chat system include opportunities to buy some choices separately, leaving more pegs for remaining choices? And another student commented to this, it would have been easier to consider these as a rider on the chosen health plan. Let me explain a little bit about the lingo there, and then we'll talk about the answer to this question. A rider is an insurance term, a technical term, meaning an additional plan, additional set of benefits that is piggybacked, is added to a core set of benefits. For a rider, you're going to have to pay a slightly higher premium. The same is true for any other benefit category that you might want or need. If it's not in the plan, you're going to have to find it somewhere else. Sometimes you can find it from the health insurance source, whether that's private or public, that may be available to you. Sometimes you may have to go to a different company that sells different kinds of plans in order to get that additional coverage. I recognize, as does Dr. Susan Gould, who originated the chat simulation with Dr. Marion Danis from the NIH, that including things like long-term care, dental, and vision in a single health plan is pretty unusual in the current U.S. healthcare market. As I've responded to another question that came earlier in the course, this chat exercise includes all of them in one, partly for teaching reasons because it's easier to consider them all in one basket, but also because the fact that they are handled differently in the U.S. healthcare system actually is a reflection of the market and demand for long-term care, dental, and vision than it is for some natural flow of insurance to split things apart. What I mean by that is many fewer people opt for long-term care than want health coverage in a given year. And therefore, when insurance companies have perceived a different level of demand for a certain product, like vision or dental or long-term care, they have typically created a different market for it in order to be able to price that type of benefit accordingly and get the most out of it that they'd like to as a health plan. On the other hand, what the Affordable Care Act is trying to do, and several states are trying to do, is to bring some of these benefits back into core plans, especially offered through Medicaid expansions or perhaps through exchange plans, in an effort to try to bundle these benefits together in a plan that is more understandable and less complex than a set of plans spread across many different domain categories. Let me answer this question in a different way, though, which is an intriguing flip side to the question. The question was, again, I purchase long-term care, dental, and vision care separately from my employer-based care. Does the chat system include opportunities to buy some choices separately, leaving more pegs for the remaining choices? Well, yes, it could. Obviously, we could redesign the chat exercise to leave out long-term care, dental, and vision for other plans and say then, okay, well, with the remaining categories, you still have to stick to 50 pegs. But if you want long-term care, dental, and vision, you somehow have to come up with that many more pegs to get those particular domains. What we're saying then is, if you want those separately, you're going to have to pay more for them. You're going to have to contribute more markers. That means paying more in premiums. What we've done with the chat exercise, by including all these benefit domains in just one plan, is to help you think constructively about the trade-offs between domains like long-term, dental, and vision versus other more conventional, if you will, categories in standard health plans like hospital, primary care, specialty care, and pharmacy. Bottom line answer to this question, sure, you can think about spending more for those plans in different domains or in different types of products from health insurance companies, but the bottom line is you're going to spend more for them. If you are in a position today to think about spending a certain amount on a health plan and other amounts of long-term care insurance or dental insurance, I encourage you to think, how are those products fitting together for you in terms of a total spending limit for yourself or your family? That's a constructive way to think about it as you try to optimize the amount of healthcare spending you're doing for yourself or your family unit. On to the next question. What happens when someone already has chronic diseases, one or more? Is it going to cost more, or you get the same number of pegs? Classic question, right? Is it the case that people with more chronic diseases have to pay more for their health insurance? The answer is generally yes. If you have more chronic diseases, you will end up paying more. But the value of insurance is that you pool risk, meaning you get some people who will naturally be expected to spend more on their health care, people with chronic conditions, in the same risk pool as people who wouldn't expect to spend as much because they don't have those chronic diseases or as many of them. That pooling that happens is a core part of the insurance principle. Insurance plans want you to jump into the risk pool with people who have different levels of risk because they want to be able to spread that risk over many, many people and offer the people who would have a lot of chronic conditions a more affordable plan. Why? Because those people understand they want the coverage. They're going to want to pay for it. Meanwhile, the insurance plans want to price their products at a point where even the people at lower risk will also opt in. Those of you who wrote on the website that you found it easy to meet the 50 peg spending constraints, you are the people who insurance plans, and to some extent the federal government, the US federal government, wants to join in the risk pool because you're going to help bring down the overall expected spending for people in that risk pool. One of the very helpful parts of the Affordable Care Act for people with chronic diseases is it has improved the ability of people to find an affordable plan even if they do have chronic diseases and would be expected to spend more. That's a whole point of affordability. And one of the earliest provisions to be implemented as part of the Affordable Care Act was to prevent insurance plans from excluding people based on the fact that they had what are called pre-existing conditions, those health problems that would have made their plans that much higher or even totally unaffordable. This does bring into question what we expect in terms of the spending as our country, as the US population, tends to get less healthy and less healthy and less healthy. And it really raises questions about just how affordable these plans can be going in the future. We have pretty good empiric or actual data evidence of how expensive these plans can be by looking at Medicare. The average healthcare expenditure for somebody on Medicare in the US each year is well over $11,000 a year. In comparison, the average spending for a person on a private health plan these days is between $6,000 and $7,000 a year. That difference is largely attributable to how many chronic conditions people on Medicare have and how frequently they get admitted to the hospital with those chronic conditions versus those rates of chronic conditions and hospitalization for people in the private plans. The more that our US population looks like people on Medicare in terms of chronic conditions, the more we will spend as a country on healthcare. It's virtually a 1 + 1 = 2 simple equation that way. Well, some of you may be wondering, well, if that's the case, then how can we offset that? What can we do to help bring down the likelihood of spending in the future? There are a few different possibilities there. One possibility is to say, well, let's try to avoid these chronic conditions appearing in the first place. Let's try to reduce the rates of heart disease by reducing rates of smoking, for example. Let's try to reduce the rates of diabetes, especially type 2 diabetes, by helping keep our population weight in better control with healthier diets and more physical activity. Let's try to reduce the rates of cancer by, again, reducing smoking and improving access to more appropriate early diagnostic tests like mammography and colonoscopy that can help us detect cancers or precancerous conditions earlier in the disease pathway and avert very expensive and life-threatening cancers downstream. Recent evidence published in medical journals just in the past few days indicates that while we know that colonoscopy can help us detect precancerous and early cancer polyps, they're called, types of growths in the large intestine, that too few Americans in the appropriate screening age group have received those tests. The answer is why? Many of these tests are covered by insurance today. Many of you in your Chat individual health plan opted for level 6, which includes full preventive services. So you want them. You recognize the value of them. So why is it that fewer than half of Americans in the screening group have gotten those tests? There is less emphasis, less attraction, less magnetism to prevention than there is to therapy in a lot of the mindset in the United States right now. And that leads us, in my estimation, towards a higher cost health system overall. There are also possibilities in terms of reducing the costs of healthcare as people develop chronic conditions to think about what things we probably may not want to invest in terms of very advanced, highly technological therapies for individuals for whom they might not make that much difference. So spending a lot to get very little towards the end of life. There are many countries around the world who have decided as a group and at the individual level that spending a lot on very advanced technologies late in life probably doesn't leave money for other people who may need technologies that may be of greater value. That hasn't taken over in the American mindset to this point, but we may need to have more consensus around that approach of deciding for yourself what you really like to be done for, regarding high-tech care in order to reduce healthcare spending related to chronic conditions. Let's go on now to the next question. Do you change the choices every year? This is a question about, well, how frequently could you change your selections in a Chat individual health plan? Typically, health plans are purchased for a calendar year at a time or for a work year at a time, a 12-month period. Sometimes those periods are shorter if you were to join a job or enroll in a plan midway through a year, and then there's a new, what's called open enrollment period, where you get to choose again. But typically, most people are going to be sticking with their choices for a given year. That can be challenging, obviously, if you have a change in your health conditions. A part of this is that if you enter a plan at a certain premium level, certain number of markers, and then you have a change in your health status that makes your health worse, that you're counting on the shared risk over that risk pool to be able to keep your premium the same, which the plan has to keep as well. Okay, your commitment to the plan is also the plan's commitment to you to keep that price the same. There are situations also where you may have what's called a major life event that happens for you or your family unit, where you may add a spouse or partner as another member of your health plan, or you may add a dependent, a child, to your health plan, which allows you to change your choices as well. Next question. I'm curious as to how you decided on the number 50 for the maximum pegs or markers. Was this arbitrary or does it have other meaning? Very appropriate question. This choice of 50 markers came originally from the chat exercise as a way to have a number of markers that would allow for enough individuality in people's selections, but not so much choice that it was really bewildering for people. I continue to think that 50 markers is a pretty good set number for this sort of exercise, as determined by the sort of variation that we see in your selections that I shared with you earlier in this session, and also the comments that you had on the course website about whether this was a difficult or fairly straightforward exercise. It falls somewhere in between for most people, and 50 markers seems to be a good way to do that. As I mentioned in the exercise and in the launch of the week 4 materials around the chat programs, the 50 markers correspond with an average annual spend on premium of $12,500, which is somewhere in the range of the typical private health plan expenditure for premiums if you were to have to pay the whole cost yourself. $12,500 for healthcare is more than the average person will spend in a year, and so it does reflect the administrative costs that are inherent in that plan, which are part of a private health plan's way of doing the paperwork to take the requests for paid claims, they're called paid services at your primary care or specialty care or drugstore or hospital, and process them and send what were your premium dollars, now in the accounts of the private insurance company, out to those providers to make sure that they are reimbursed for the healthcare that was provided. By most estimates, the administrative costs of a private health plan are somewhere in the range of 15 to 20%, depending upon the health plan and whether it's a large or small company. In comparison, the administrative costs for a public plan are somewhere in the range of 7 to 10%. That difference has to do a lot with the number of people who are working in the private system versus the public system to process those claims, and also the pay scale of people working in the public versus the private system. And administrative costs are one of the areas that critics of the U.S. healthcare system have said represent an opportunity to do better in terms of the overall costs. In fact, the Affordable Care Act includes language that limits the percentage of premium dollars that can go towards administrative costs of the health plans. And if private health plans spend more than their allowable amount on the administrative costs, they have to pay a penalty to the federal government. Next question. For those who do not have a background in medicine, some choices could have been perplexing. Will you be simplifying these? What a wonderful question, because it points out that the vast majority of people coming to a health plan decision may have less preparation for that decision than they would really like. Take a moment and think about when you last made a major purchase of something on the order of $12,500. Would that have been a purchase of a car, a major set of appliances, a half year or year of school, of tuition? There are different examples of other major expenditures that we make in the United States, or that the United States population is asked to make. Few of them have to occur every year, like health insurance does, in order to get the maximal protection. In other words, this is a very, very impactful or important decision to make, and has a lot of implications in that next 12-month period about what may happen for you or your family. You want to be prepared. But what resources are out there to help you prepare? This course hopefully is serving as a possible resource for you. But when it comes down to it, a lot of the decisions that people make about healthcare and the benefits they'd like in their health plans are focused on what we call the grapevine. That ability to talk to others who may have made similar choices and say, well, what did you choose? Why did you choose that? how did it play out for you in terms of your experiences last year? And some of those experiences are very positive experiences in terms of having coverage when something really unfortunate happened suddenly, or maybe negative choices in terms of saying, well, gee, I paid a lot for that health plan and I didn't use very much health care at all. That exchange of information on a person-to-person basis is the way that people have been making health plan decisions for a long time. There are some resources online that may help you make a better decision yourself, but a lot of this does come down to your own perception of risk. Very few consumers feel very well prepared to make a health plan decision in terms of the benefits and what is offered. There's a lot of fine print in these certificates of coverage, or COCs, that insurance plans have available. When in doubt, if you have questions about a particular type of benefit or the cost sharing that would apply in certain circumstances, I encourage you to get all the information you want online, and especially in a phone conversation with a representative from either a public plan or a private plan when you have some choice to make about what those plans offer you. A question from outside the United States, and we know that about a third of the students enrolled in this course are coming from a country outside the United States. Is using chat for getting a health plan mandatory in the US? What is the link between chat, private insurance, employer-based insurance, Medicare, Medicaid, etc.? Some helpful students stateside answered questions like these on the website. I include it here mainly because it was a fairly common question for our students from outside the US, and so I wanted to address it myself. Using chat is not mandatory for getting a health plan in the US, although I will say that thanks to the efforts of Dr. Gould and Dr. Danis, some communities have used chat and some employers have used chat to help their employees understand better what options are available to them. So while it may not be mandatory, when Dr. Gould and Dr. Danis have helped bring chat out to users, those users have said, I feel so much better prepared to make the choices that are important to me in my health plan. While it's not mandatory, it may be something that's really advantageous to people to use. In terms of the link between chat, private insurance, Medicare, Medicaid, chat is purposely designed, and I'm using it in this course, to help you understand core elements, core fundamentals of the idea of coverage, whether it's happening in the private insurance realm or in public plans. In the public plans, it would be a person or a team in Medicare or Medicaid at the federal level or the state level deciding what benefits should be in this plan. Oftentimes, people in a public plan don't have a lot of choice about what's available, but they may have some choice. For example, in Medicare, for Medicare Part A, which covers hospital expenses, there usually aren't that many choices available for a person in terms of their Medicare Part A coverage. In comparison, for Medicare Part D, which covers prescription drugs, in a typical state in the US, there are 30 or more plans available for individuals eligible for Medicare Part D drug coverage. 30 or more plans. How can you make sense of that? Well, fortunately, Medicare Part D, the federal government Center for Medicare and Medicaid Services, has a website that allows you to go online, enter in the medicines that you take or that a loved one takes, and find the plan that is best for you in terms of the expenses that would be expected in the next year. Sometimes plans may differ by double or 3 times the amount in terms of the cost, and so therefore a tool like the one that's online for Medicare Part D can really be helpful for people in terms of understanding what plan would be best for them. Let me mention 2 caveats from my own research, though, about those Medicare Part D plans and your selections. Problem number 1. The plan that you have or that a loved one has, a senior has on Medicare Part D this year may not be the most advantageous one or the best one in terms of price for you the next year. That's because just like health plans can change year to year, so do the contracts between the Medicare Part D drug plans and the pharmaceutical companies that are setting up different bulk discount rates for those plans to buy certain medications. Because those contracts change between the health plans or the prescription drug plans and the pharmaceutical houses, the expected costs of providing those medicines can also change. Make sure you shop wisely, and that tool online can be very helpful for that purpose. Challenge number 2 is a bit more difficult for everyone, And this is something that I face with my own patients. For example, let's imagine that someone is on a high blood pressure medicine and a high cholesterol medicine, and is also obese and hasn't developed type 2 diabetes yet, but may in the next year, and we're going to be screening for it. Is it possible to choose a Part D Medicare drug plan thinking ahead to what medicines you might be on sometime in the next year? And I've gone through the plans online to ask this question. For example, if you're already on a blood pressure medicine and a high cholesterol medicine and you think those are going to be staying stable, you might pick plan A. But if you say, well, but what if I have insulin or an oral medicine for diabetes added? Well, then you might actually choose plan B or plan C or plan D at different amounts depending upon which medicine you choose with your doctor. So I encourage those of you who may be considering situations like this to take this question, take this consideration to your doctor and say, well, doc, I know I'm trying to prevent type 2 diabetes from happening, but if it comes on in the next year, what medicine are you likely to prescribe for me? And then you put that medicine into your basket of potential medicines on the Part D drug chooser online and see which plans would be best for you. If you're fortunate, it'll be the same plan you would have wanted anyway for your blood pressure medicine and your cholesterol medicine. But if it suggests another plan, you can see what the difference might be in terms of the spending. I'll give you a heads up that one of the key differences will be whether your doctor plans to give you a generic medicine or a brand name medicine. There are usually tens to dozens to hundreds of dollars worth of difference in your premium that you will pay if your doctor expects to prescribe for you a generic medicine versus a more expensive brand name. That's also encouragement to pick that generic medicine, just like we saw in the chat game in terms of picking the generic medicines and what the copays would be in your different levels of pharmacy benefits. The last question on this screen is, was the chat plan meant to include those who are not covered by Medicare and Medicaid? This is another very perceptive question, which points out that for many people in the United States, and probably most students in this course, they have always known a U.S. healthcare system with Medicare and Medicaid in it. That points to the enduring legacy of the decisions in 1965, which we heard about in such detail during week 2, looking at the administrations of Kennedy and Johnson and the subsequent presidents. Medicare and Medicaid have shaped a huge part of the U.S. healthcare system at this time. What CHAT is meant to do, as I mentioned a few minutes ago, is to take you through the decision making that goes on behind any health plan, whether it's in the public sector, Medicare, Medicaid, S-CHIP, VA benefits, Indian Health Service, and or the benefits in private health plans. It's meant to be an all types of coverage type of exercise to help you understand the decision making and the trade-offs that go on, usually without a lot of input from you, but which I hope can go on with more input from you in the future about what you would prefer. Another very good question from the group of students in the course is, I could not find any coverage for pregnancy, in other words, antenatal or prenatal care, and postnatal care, that's for the mom after she's delivered, and childbirth, while infertility treatment is covered. How can you explain this? Well, it really depends on how you view the patterns of care around pregnancy, childbirth, and postnatal care. If you think about the most common forms of prenatal care, that's in primary care and perhaps some specialty care if the mother has some complications of pregnancy. Then you think about childbirth. Well, over 98, close to 99% of all babies in the U.S. are born in hospitals, so that would be hospital care. And in fact, it turns out that delivering babies is one of the most common causes of hospitalization in the U.S., common prompts for hospitalization in the U.S. every year. And being born in the hospital is, I believe, just the second most common reason that all children are in the hospital each year. So the hospital is a very common place, and hospitalization or hospital care in CHAT would encompass the labor and delivery for the mom and the nursery and or neonatal intensive care unit time for the baby. In terms of postnatal care, well, then we shifted back to the outpatient arena, the primary care and specialty care. Some of you may be thinking, well, but what about a midwife, or what about a doula, or what about home visits that may occur? And you are so right that this chat model is reflecting predominantly what would be a very U.S. style type of healthcare provision, tending towards more high-tech, more intensive types of healthcare provision. And there have been innovations, and these innovations are used more broadly in European countries, other countries around the world, where midwives play a much larger part of the prenatal and labor and delivery context. And then you have home visits after childbirth for the mom and child from doulas or other birth attendants or home visiting nurses, who we know from a lot of very good medical and public health research can make a big difference for moms and for babies and for the family dynamic. You could think of those as encompassed in some of the home health benefit that's in chat, but I'll be frank with you that oftentimes that isn't part of that home health component. Instead, it would probably be a less expensive version of the prenatal care that's described in the primary and specialty types of visits. Infertility is covered because infertility fundamentally is different than the types of care that are currently available on a very broad basis regarding prenatal care and labor and delivery and postnatal care. First of all, it's not any of those things. Infertility comes before the conception of the child. It's requiring usually quite high-tech types of approaches to help women conceive and help their partners fertilize the egg from the mom and get that pregnancy started. That's when then the other coverage would be relevant, that's already part of the chat exercise. That's why fertility is separate, and we don't see childbirth and postnatal care pulled out differently from the benefits that you see in the chat benefit options. Next question. Where do genetic diseases and birth defects get covered? Which option? Well, these are put all in one, and I understand why, because many birth defects are related to some sort of genetic disorder. But they're covered very separately and, in fact, foreshadow some of what may be coming in the U.S. healthcare system in the years ahead. Let's take birth defects first. Birth defects are covered fundamentally in the hospitalization arena for kids and in the primary and specialty care arena, perhaps pharmacy as well, perhaps some other medical services if it requires physical therapy, occupational therapy, ambulance services, etc. In other words, birth defects, because they can be so challenging to deal with, often require types of healthcare for many of the different benefit domains that are part of the chat exercise. Birth defects have been around as long as we've been trying to do better with healthcare, because they are common, and they are a common reason that children do not do well early in life. Birth defects are a major source of mortality, a major reason that children die before age 1. They bring a lot of attention from the medical system to try to remedy them, and some of the most remarkable innovations and inventions over the past 50 years have happened around trying to help babies and their families address birth defects. But those do require an investment of resources, and they are part of understanding how we can pool risk in the overall group of children who are born in any given year. Keep in mind that across the country, about 40% of infants are born on Medicaid. That's because many young families are living in poverty or near poverty and therefore qualify for Medicaid, and also because the income eligibility for Medicaid is higher for children than it is for adults. So even though the parents may not qualify for Medicaid, oftentimes children do, even in states that find it hardest to meet their Medicaid obligations. So 2 out of every 5 kids being born on Medicaid means that we're pooling a lot of risk in Medicaid when it comes to those higher risk kids who may have birth defects. And fortunately, as a pediatrician I will say this, fortunately, the vast majority of children who are born healthy. Now let's talk about genetic diseases. Genetic disease, and I will say more broadly, the opportunity to test for the risks of genetic disease are something that are really challenging a lot of the notions we have about what insurance plans should cover. First of all, there are the challenges of if an individual knows that he or she carries a mutation in a gene that puts him or her at risk of developing something in the future, does the insurance plan have a right to know that? Will the insurance plan find out anyway by taking a look at what test results may be available from a battery of tests that may be run through a newborn screening test or a type of genetic analysis. In other words, people have been worried for many years, decades really, that by doing genetic tests, insurance plans might deny care to some people who had risks. Now, with protections offered through the Affordable Care Act, it's much harder for insurance plans to stop people from joining up. However, we still have this onrushing wave of information we will be having in the next few years about people's genetic tests and what they mean for their likelihood of getting particular health problems. And insurance plans will be starting to build those assumptions into their cost projections and their expectations of premiums. So we need to be careful about how we gather such information, how it's then translated into the expected costs of healthcare, and what this means for how we try to manage the information we get about genetic risk. What I mean by that is, what if we find in the future that there's a particular gene that's associated with developing cardiac disease, narrowing of the coronary blood vessels that leads to heart attacks? What should that lead to? People throwing up their hands and saying, well, might as well just eat what I want because I know I'm going to get heart attacks anyway? On the contrary, even if somebody does have a genetic predisposition or a genetic risk, oftentimes we find that the environmental exposures or the context of their health also has a major, if not predominant, impact on their eventual health outcome. So you can have a genetic risk, but by eating healthier and exercising frequently and really taking good care of yourself, you can minimize that genetic risk for your overall health outcome. To say that another way, the risk is not an absolute guarantee that you will end up with that health problem. You as an individual have an opportunity to modify your health behaviors in a way to minimize the risk of a bad health situation for yourself. I would say personally, as a physician, what I look forward to is having that genetic information that can help me have a broader and more in-depth conversation with my patients about what would be the best priorities for them going forward to live the healthiest lives that they can. Question number 3 on this slide. What stops people from loading up on preventive and testing pegs while healthy and then switching to those areas of need when they get sick? Well, I have to say this is a great question from somebody who obviously is thinking very strategically about how to set up their health plans. It connects back to an earlier question we had on the past slide about how often you get to change your plan. You only get to change your plan once every 12 months or so. And insurance plans do this for a couple reasons. One is they want you to try to plan ahead and purchase a plan that would be the best for you given your potential risk in the future, knowing as much as you do or can know about those risks. They also do this because they want to prevent people from paying little up front to just focus on preventive and, let's say, some screening tests, and then switching their costs to the higher cost plan whenever they get sick. Because fundamentally, that makes it very difficult for them to help safeguard the population against these very high cost episodes of care that involve hospitalizations. The way to do that so that insurance plans can function the best that they can for what is still the largest source of coverage for the U.S. population, which is private plans, is to have people paying into those plans whose risk of very high costs are low enough that they're going to pay more into the plan as premiums than they're going to receive this year. They may end up paying more or getting more from that plan next year if they have an unexpected hospitalization. That's fine because they've paid more in the past and things can balance out. There needs to be an appreciation among the U.S. population that if we want the choices and the access that private plans typically market themselves regarding, there is an increased cost in terms of the administrative cost that I alluded to a few minutes ago, and the way that the premiums are structured to meet the needs of the health plans to get enough money that they can run their plans and make a bit of a profit each year as well. If you don't like the sound of a health plan having a profit each year, there are really two options. One is to try to shift all the health plans to nonprofit status, or to shift to exclusively public coverage in the U.S. Those proposals have been made before, but for one or more reasons, they have not carried the political argument strongly enough to really change things at the national level. Question number 4 on this slide. PEGs now assume that you have healthy and non-healthy people in the same group to spread out costs. That's true. That's the risk pooling that we talked about before. Yet, as costs increase, it creates a death spiral. As healthy people drop out, and unhealthy people have no choice but to stay in and incur the costs alone. The so-called death spiral that this student is asking about has been described before, and this student is absolutely right. If we have a situation where the costs go up so high that healthy people say, this is absolutely not affordable and doesn't make any sense for me to buy into, then they will drop out, and the uninsured will have, the people still left in the plan will have an increasingly unaffordable plan to try to pay for each year. What prevents the death spiral? Well, a couple things do. First of all, you have the perception of risk. Among healthy people, people who are fortunate enough not to have many chronic conditions or conditions that are so severe they need a lot of health care, they still perceive that they're at risk for the possibility of hospitalization or several episodes of emergency care, expensive pharmaceuticals, etc. And they are willing to pay more for that protection against that risk. That helps keep the healthier people in the plan so long as the amount of risk that they perceive is larger than the increase in premium that the plan is asking for. It's possible that health plan costs could increase so much because of the burden of chronic disease that we've talked about earlier in this session, that even the people who are generally healthy and perceive some risk may not be willing to pay for this much more in premium than they would otherwise have to pay by themselves. But we haven't really gotten there yet. And as the Affordable Care Act helps people buy plans on the health insurance exchanges with subsidies, that's buying the population some time in terms of these plans being more affordable to them while they remain healthy. The other aspect of the death spiral and the counterweight to it is the individual mandate, which the Affordable Care Act also includes. Just to review, the individual mandate in the context of the Patient Protection and Affordable Care Act stipulates that the vast majority of people in the U.S., unless they are destitute, absolutely not able to pay the penalty, will be required to have coverage either in the public sector or private sector for all 12 months beginning in January 2014 and going forward from there. If they do not have demonstrable coverage, they will pay a penalty. What that does is it essentially encourages people, pushes them, pulls them into coverage that otherwise they may think about not buying. A primary group affected by this are the so-called young invincibles. Young invincibles, who are individuals generally between the ages of 18 and 35 who perceive that they have very low health risks. They're generally healthy, and they say, you know what? I'd rather keep my earnings or my available savings to pay for other needs I have, not for these unexpected health events that may be expensive, but I don't think I'm going to have. Those young invincibles, because they are so low risk in terms of their health, are generally people who help bring down the risk pool level for the United States population and therefore help keep the health plans affordable, health plan premiums affordable. That's generally the idea about how to counterweight the death spiral, either through making sure that the premium increase that healthy people face is smaller than the amount they're willing to pay because of their risk, or to mandate that they have coverage and thereby to strongly encourage them to stay in the plans and bring down the overall risk. Question number 5, bullet 5 on the screen. Why do we have to choose a set of benefits for disparate groups at all? Why not give people the pegs and let them choose cafeteria style what they want? HR, or human resources plans, used to offer cafeteria style benefit selections. Then all groups can be accommodated. This is the principle of choice, American style, writ large across the entire set of health plans. Wouldn't it be fantastic if we could dial up or dial down every part of the benefit selections? Wait a minute, we sort of did that for the chat benefits plan, didn't we? Now, the goal was in chat to see how alike or different our selections might be if we did have that benefit. And you can see that although there were common selections, and I showed you those in the earlier part of this session, there were differences too. And there were key trade-offs that people made. And hopefully you saw that there are some different types of personalities, you will, or profiles of people who are making different sets of selections together in ways that really mean that people are quite different. So when people are different, why not allow them to have this cafeteria-style selection? Here's why. As the questionnaire points out, HR plans used to have, emphasis on used to, have cafeteria-style plans. They become very difficult to administer in several ways. First of all, they require even more administrative costs for the insurer to keep track of everybody's different types of benefits, to inform people about those benefit options, to make sure that those different options are available in different ways administratively for people in the plans. That creates more administrative costs, and as I've talked about, generally plans are trying to reduce their administrative costs at this time because they are under constraints in the Affordable Care Act to keep those administrative costs at a manageable level. Second, the more choice you allow in terms of benefit selections, the less you're able to pool risk. Pooling risk fundamentally is about understanding for a given set of selections what are the overall levels of risk and what does that mean in terms of the premium, what's called the rating of the plan. The more that you allow people to choose across, the less you're able to maximize the benefit of that pooling of risk. And when you don't maximize benefit of pooling risk, what happens to premiums? They go up. They get less affordable, and people choose not to buy into those plans. So what human resources managers have found is, although people say they want more choice, they are willing to trade off some of that choice in order to have a more affordable plan. However, at the bottom line, what we have in the U.S. healthcare system is a great deal of choice. Across the different health insurance exchanges that have been set up as part of the Affordable Care Act, you usually have several, if not a dozen or more plans in each state that are vying for the attention of different consumers. It turns out even though that those plans have different covers on them, different wrappers, if you will, the benefits domains within them are very, very similar. The types of benefits they're going to have are very, very similar. And so where they are principally distinguishing themselves is on the different copays that they're going to have, and also the different access to different providers, different hospitals, different major primary care and specialty groups, etc., in different areas. Therefore, what's going to lead somebody to choose Plan A versus Plan B will probably not be so much around the benefits as it will be access to particular doctors or certain co-payment and co-insurance expectations when people use that care in the future. Bottom line here, in terms of choosing a set of benefits, the most efficient way to do this would be to have just one size fits all for everyone, but that's not appealing to consumers. The most appealing to consumers on the face of it would be to have an infinite number of benefit selections, but that's not practical from the administrative point of view. So there's some sweet spot in between one size fits all and infinite number of choices that is the best in terms of the administrative complexity and the affordability of the premiums. The last three questions here are really questions that are broader than just chat, and I've tried to take my answers so far broader than just chat to the U.S. healthcare system. But these three really push us to think about the broader dynamics of the U.S. healthcare system as chat pushes us to consider them. The third bullet from the bottom was written as, given the distribution of healthcare spending in the United States, where 1% of the population accounts for 22% of total annual healthcare costs, 5% of the population accounts for 50%, and 10% of the people account for 65%, then why does it matter how our individual plans are set up? Why indeed? After all, if we set up a plan this way, and if, let's say, there were a certain number of private plans and a certain number of public plans, but there's this, what economists would call distortion of the market in terms of a lot of spending happening for a very small number of people, we have to ask ourselves, well, then what was the point of constraining those choices in the first place? Because obviously, if 1% of people are responsible for 22% of the expenditures, then they didn't have their costs constrained, did they? They didn't have some limit on their spending. Very fair point. And I can see where this would seem to argue that this sort of limit is a false one, because after all, when it comes to it, we just blast through the spending limit and end up paying for health care, even if it wasn't necessarily the idea at the beginning of the year that's how the benefits would play out. My response has a couple different parts to it. First of all, in countries outside the US, where there is a stronger public consensus around having some sort of spending constraint as part of a major, oftentimes universal set of health plans or health priorities, there is a constraint on spending such that you don't see this distortion of 1% accounting for 22% of the costs. There are still some distortions because that's how health care utilization pans out for people in terms of unexpected costs and severe illness. But it's not so distorted because there are actually decisions, tough decisions, made about what health care is really constituting an extraordinary measure. For example, in a country like the United Kingdom, Great Britain, there are age limits on who can get a kidney transplant for kidney failure. Now, in our country, although there may be clinical decisions about who would be appropriate for a kidney transplant and who wouldn't be, age is not part of the decision-making process. In fact, if you ask most Americans, should there be an age limit, although I'm not certain that that survey has been done before, if we were to do it, I bet people would say, no. If they can safely, clinically get the kidney transplant, they probably should. But in the UK, taking a look at their data, they have found that above a certain age, that person who receives the kidney transplant is just not likely to survive very long. And so they've made the decision that even though it seems like this would be fair to give everybody the kidney transplant, it isn't actually fair to give it to people who won't be able to use the transplant very long. They'd rather use that scarce resource of the kidney, the available kidney, and give it to somebody who's younger, who can benefit from that kidney transplant longer. That is a hard decision, no bones about it. It takes political will, it takes a willingness to have the conversation, and ultimately it takes a cultural acceptance of the trade-offs there between less time in life with that kidney transplant and more time in life with that kidney transplant. The other part of this, though, and part two of my answer, comes to how we are making decisions about when the spending should occur in our own individual decisions versus decisions by a plan. And what I mean by that is it's possible as an individual to say, you know what, I wouldn't want this type of extraordinary measure taken from me. So for example, you might decide, well, if I were to be in an auto accident and I had such severe injuries to my head that I was in a coma, that I wouldn't want people to shock my heart if it stopped. Okay? Deal with the whole coma part, but if I am in a coma and my heart stops, I don't want to be resuscitated. That's what that's called. Okay? If you feel that way, you can then speak to your doctor about that, speak to your loved ones about that. Make sure they know what your wishes are, because not wishing that anybody should get in an auto accident and have severe head injuries, we in the medical profession would always want to know what your wishes are. Too many times in the U.S. healthcare system, the healthcare providers do not know what the wishes would have been of the person who was injured or severely ill and not able to respond, not able to tell us. And if we know that someone would not want extraordinary measures taken, then we can be comfortable with that decision and make decisions about their care accordingly. In other words, don't have a group of people in a room somewhere necessarily making decisions. Critics of the Affordable Care Act have called that idea having a death panel. Instead, have people affirming their choices up front in a way that says, you know what, I appreciate you trying to be helpful to me, the healthcare profession and healthcare providers, but please do these things and don't do these other things. By having those directives, called advance directives from patients, we can do a better job of allocating our precious healthcare resources to the people who would want them and not providing them to people who don't want them. Second from the bottom, does the healthcare establishment think consumers have so much control over what they spend with their healthcare dollars that they can control costs themselves? Most consumers of healthcare are not professionals or well-read on the subject. It seems like more healthcare rationing to me, which always hurts the most unfortunate in our society. There are so many ideas in this point, and I want to try to hit on a couple of the major ones. First of all, does the healthcare establishment think consumers have so much control over what they spend with their money that they can control costs themselves? In fact, if there is a healthcare establishment that has one idea about this, it is that they wish there was more of a conversation with patients about this issue. There is a growing idea and affinity for an appeal to the idea of shared decision making. Why? Because it's centered on the patient, it involves the patient and the healthcare professionals who are involved, trying to make the best decision for each patient. It's frequently a sensitive topic about whether cost is part of that conversation. And I would argue it should never be the only consideration. But I also would suggest that in some or perhaps many conversations, it can be a helpful part of it, because after all, people do understand that money doesn't grow on trees. People do understand, while they would want something for themselves perhaps, that there also need to be resources for others. So if that is part of the conversation, is an open part of the conversation to consider along with the benefits and risks of particular therapy, then it can be a constructive part of the conversation where patients can bring their views and healthcare professionals can bring their knowledge and perspectives as well. The other part of this is the comment about, it seems like more healthcare rationing to me, which always hurts the most unfortunate in our society. This is a wonderful point in ways that I believe the questioner intended, but I wanted to highlight as well. What goes on most often in the US healthcare system is a form of rationing that if you ask people, they say, oh, well, we don't ration. But in fact, there is a lot of implicit or hidden rationing in the US healthcare system. This student is correct that that implicit rationing always hurts the most unfortunate in our society. Why? Because they are the ones whose care is rationed. The most unfortunate are the most likely to be uninsured. The most unfortunate are the ones with the least access to care. The most unfortunate are the ones with the least ability to pay for their own health care if they don't have coverage. The implicit rationing in the US healthcare system is that if you can't pay, you have less of a chance of getting the care that you need. What other countries do is they make their rationing more explicit. Notice I said more explicit. I'm quite confident, unfortunately, that there's probably implicit rationing occurring in every system. But the more that rationing, if it occurs, is explicit, the more that we can talk about it, make decisions in accordance with it, have community conversations about it, and come to collective decisions about how we want to move forward as a country. Part of the challenge of the rapid rise in healthcare spending on a per-person basis in the US over the past 50 years is the challenge that we are willing to implicitly ration, hurting the unfortunate, and unwilling to explicitly ration. In fact, the idea of explicitly rationing causes major political discourse and shouting in town hall meetings like it did during discussions of the Affordable Care Act in 2009. My suggestion, and this is not just in this course, but in my writings before this course, is that the US can continue to look different than just about any other healthcare system in the world, but we're unlikely to really get control of spending in the US healthcare system unless and until we have a more deliberate, respectful conversation about how we will explicitly ration. When I say that, people often ask, well, what on earth are you talking about? What does that look like? Here's one way. We have had, over the past decade, a move gradually and in a more accelerated fashion towards using generic medications instead of brand name medications. Those generic medications have helped contain what was previously rapid growth of spending on pharmaceuticals. That has happened through a combination of implicit and explicit rationing. Implicit because if you're asked to pay more at the pharmacy for your prescription that's a brand name, and then you ask as a patient, well, isn't there a less expensive version of that? And then you have a conversation with your provider about making a change the next time. What's happened there is that your care has been rationed, arguably at no harm to you if the generic medicine is equivalent in effect to the brand name medication at lower cost. What's explicitly happened is if you read the fine print, or even sometimes the easily readable print for your drug plans now, if you're in the private sector, or if you have a choice between Medicaid managed care plans on a Medicaid plan, or the Medicare managed care plans, Medicare prescription drug plans for Medicare Part D, you can actually see the copay amounts for generics versus brand name. That's explicit rationing made clear to you that then you can act on as a consumer. Now, no one's going to market with 3 or 4 or 5 stars and say, rationing in action. The companies that provide these plans know better than that, because rationing is a political third rail. It's very sensitive. Nobody wants, in the US context, to think that they're being rationed or to be accused of rationing. But it is rationing, and it's actually being effective in terms of the types of medicines that people are taking and how well it's helping contain growth in spending on pharmaceuticals. That leads us to a pretty profound, very broad question at the bottom of the slide here. How is the Affordable Care Act designed to help constrain healthcare costs? There are several components of the Affordable Care Act that are designed to help constrain healthcare costs. And the fundamental one, at really the cornerstone of the entire idea, is that if more people are covered in the US, if more people have coverage, then the opportunity will be to help them get into primary care or appropriate specialty care, as they should, and avoid the most expensive types of healthcare in the future that are related to hospitalization. That premise is one that remains to be proven for the particular population of Americans who are going to get coverage over the next few years as we roll out the Affordable Care Act. That's the main cornerstone of the idea about how we can try to, what's called, bend the cost curve, which means healthcare costs will likely continue going up, but not as rapidly as they have in the past. There are also provisions where payers are going to be contracting with different types of provider groups called accountable care organizations. The idea is that these provider groups are going to sort out amongst each other who gets what share of those premium dollars that the payers are going to pay to the accountable care organizations to provide the wraparound 360-degree care for each patient. Whereas payers negotiated separately with hospitals, primary care groups, subspecialty care groups, and other organizations separately, as I mentioned in the past, the idea of accountable care organizations and other organized systems of care, as they're called, is that providers will have to work out how those different relationships will be sorted out, who gets what piece of the pie, and payers just pay the provider groups a set amount and not worry about the details and how that works out. So those are just two main examples you may see in the newspapers, magazines, press accounts, online descriptions of the Affordable Care Act, and they are two main ways that we can control costs under the Affordable Care Act in the future. I would hasten to emphasize, as part of this course, that I really hope you're thinking about ways that you can, as a patient, provider, part of a payer, or in public health, also control the growth of costs in the Affordable Care Act and in the era that the Affordable Care Act distinguishes, but that the Affordable Care Act does not fully explain. There is so much to the U.S. healthcare system that is not the Affordable Care Act. And I really hope as part of this course, you've been getting a sense of how you can have an impact on that, whether you are directly in contact with the Affordable Care Act or not. Wrapping up here, if you have other questions and would like to post them in the Week 5 discussion forum or in other parts of the discussion forum, my course team and I will get to them as we can, as time allows, and I will try to synthesize answers across many different students' queries as well. I hope this has been a fun live session, and I look forward to interacting with you on Week 6 as we hear from an expert panel about the future of the U.S. healthcare system, and I provide some wrap-up comments to follow. Thanks very much for being with me.